Okay, so I'm recording again. Hello. Uh, we're going to talk about chapters 20, 21, and 22. We covered 20 and 21 in class, so it'll be kind of a review. 22 we didn't get to, but we'll cover it here. So without further ado, and it has been a very um, busy day, but not as tired as I was before, so we'll get started. I want to share my screen, eating disorders, and share. Okay, I am screen sharing now. Okay, hopefully this will go. Oh, yay. Okay. Eating disorders, like we talked about in class, there's several different types of eating disorders. The ones that we focus on in this class are anorexia and bulimia, but they do have other nighttime eating disorders and some of the other ones out there. Eating disorders, eating too little to eating too much. There is lots of binging and purging with bulimia, but not necessarily all the time with anorexia. Remember, the anorexia is a prideful thing that they can resist not eating, or they can resist eating and they not eat. And they find pride in it, where the bulimic people, they are more guilty about their binging and purging. Other eating disorders, binge eating disorder, night eating disorder, pica, which we've talked about, and the orthorexia nervosa. Biologically, they think it has some sort of genetic vulnerability related to the hypothalamus in the areas of hunger and satiety. They do blame norepinephrine, serotonin, and we discussed at class how those two neurochemicals, they actually assist with satisfaction. So, happiness and satisfaction. So, which is pretty much why people eat the way they eat. They're looking for their reward system. The latest, I think, that I've seen in the research is the whole dopamine addiction thing causing problems with binge eating disorders, but it's still too new. It's not in the books yet, so just go with norepinephrine and serotonin. Developmentally, a lot of times people with eating disorders, they really struggle to be themselves and know who they are. They come from overprotective families. They may not see their body as something that just needs to be fueled. And then they take great emotional release from eating. And then some people just have that self-concept about their body that they need to be perfectly thin, um, or bones are sticking out in. I know we talked about, you said her name was Eugenia off of TikTok or YouTube or one of those. If you haven't looked her up, look her up. She's a good example of anorexia. Other factors, family influences, sociocultural factors, got to be skinny for school, all the girls are thin, kind of thing. You can look at table 20.1 if you want to. Cultural considerations, we have eating disorders more prevalent in, I'm going to move myself down here. There we go. More prevalent in the industrialized countries. We have a overabundance, it seems, of food. And anybody who comes from a different country, that's one of the first things that you hear usually is that we have so much. We are so blessed. I've heard that from exchange students and things like that that my daughters have been friends with over time. There's just so much that we have. So that kind of feeds into it. So, one current biological theory about eating disorders does with the cerebellum, and we say no because we know it's the hypothalamus, which is near the limbic system, which is in your cerebrum. So it's false. Anorexia between 14 and 18, so a younger person, eating disorder. Usually they don't, they hide it very well. They can be around food, they can prepare food, they can serve food, they can be everywhere around them. And unless you're not watching, you don't recognize that they're not eating. And so they're very resistant because according to them, there's nothing wrong. They don't need to eat. Very uninterested in thinking they have a problem. So we want to get weight restoration going back on, those fluid electrolytes corrected. Lots of times you're going to see these guys in the emergency room with some sort of cardiac issues related to a lack of potassium or a lack of magnesium in their diet. And it's really damaging. Psychopharmacology, we can give them the tricyclics, which is your amitriptyline. We can give the neuroleptics, psychotics caught my brain in a brain fart there, but the cyproheptadine and the olanzapine, and then the SSRIs, which is the fluoxetine. Therapies are good, but again, it's going to be individual or family. Family therapy is tough, so I would probably say individual first and then bring family in because families tend to internally blame themselves when it really has nothing necessarily to do with the family as a unit. So individual, then family. And if you're doing individual, you probably ought to do cognitive behavioral therapy to teach the person to just look at food as a fuel and not as something that's going to be bad for them or something that's going to, be negatively received by other people. And it's very hard when somebody is completely anorexic because they just don't have that desire to eat. So it's kind of sad. Bulimia, they're a little bit older, 18 to 19, and usually it's binge purge. So, and the purging can be diuretics, it can be stool softeners and laxatives. It can be excessive exercise. It can be vomiting. It can be any of those things. But binging usually happens after a period of trying to diet and the diet fails and then they binge. So the people know that their behavior is not right. So they really, really try to hide it. Cognitive behavioral therapy, yes, teaching them again that food is fuel. And that's all its purpose is. And really that's all its purpose is. We don't eat to be happy. We don't eat to, conform to social norms. We eat for fuel for our body. Okay. Treatment, we can do antidepressants. SSRIs are very good at helping people gain weight. So anorexics for SSRIs, maybe. Bulimics, you may want to go with something that's a little edgier, something probably like a SNRI. Effexor, Cymbalta, that tends to have a calming effect for certain people. So, but antidepressants, class effect. Okay, moving on. Oh, so here's our question. Anorexia, remember, is the younger, 14 to 18, 10's a bit too young, but 14 to 18. And anorexics a little bit older. So eating disorders, anorexics, again, they are perfectionistic, eager to please. They're the good child in the family. They do everything parents want them to do, except eat. The bulimics usually are very impulsive. Anorexics, when you look at them, they're going to be emaciated, very lethargic, and bulimics are going to be very close to what you expect people to look like. And the fact that they hide their eating disorders just solidifies that it's pathologic. So they will have labile moods. They may be sad. With bulimia, usually they're pretty cheerful. They're trying to hide. So they're not going to be expressive to you at all. We want to talk to them about the thought processes, the content of thought. Most of the time for bulimics and anorexics, they have a preoccupation with food. They see it as more than just fuel for the body. Their sensorium and intellectual processes are going to be decreased in anorexia just because they're not giving themselves the food they need for their brain. Bulimics probably going to be pretty normal. Judgment and insight, bulimics are ashamed, anorexics, they just don't think anything's wrong with them. So that's called limited insight. And for both of them, the self-concept, roles and relationships, and self-care considerations are pretty low to non-existent. We look at what do we want? Goals do we want? We want to have a balanced food and fluid intake that's healthy for the body. We want to get rid of compensatory behaviors. So if someone is vomiting, we want to stop that. If they're using laxatives all the time, we have to stop that. It's very difficult though, teaching those coping mechanisms that are not related to food. Lots of people, that's how they've learned to cope with certain situations. Break up with a boyfriend, you eat a box of Oreos, and you feel guilty about it and you go puke it up. So learned behaviors are more difficult to change. We have to get them to talk about how they feel about their diet. What are they feeling? What are they experiencing? And then verbalizing, acceptance of themselves and their body. Sometimes it's hard. So, if they don't eat, remember you want to keep them in line with you about 90 minutes eyesight so you can see what they're doing. We want them to have nutritional intake that's adequate. So, if they don't eat a certain percentage of the meal, you may want to supplement with some sort of like Ensure or Lucerne or something like that. You can mandate TPN on people with anorexia if you need to, but it's not a lot of calories. Again, we have to get them stable if they're unstable, and then work on their thinking related to the food intake. And again, working on those coping mechanisms and dealing with their body image issues. And did it work? Did it not work? Community admissions, only if medically necessary. We can do this in the community. So again, partial hospitalizations, only acute care inpatient if they are physically unstable. Again, individual therapies, and then self-help groups do work, but again, that individual therapy first. I know in Lima we have an Overeaters Anonymous. I've been to a couple of those meetings just to see if they would be good for students to attend. It's kind of like a 12-step program for people who have food addictions. Yes, it works. The support system works. You have a sponsor, somebody you can call if you feel like you're going to be doing overeating, or if you're going to be eating the incorrect things and then compensating. So it's not a bad idea, but again, that individual therapy really should come first. And education to the families. There are eating disorder guidelines out there and screening questions. You're welcome to look at all this. Usually, unless you're working in an eating disorders clinic, you're never going to see these kinds of questions. These kinds of guidelines, everybody has them for every disorder that we have and how to take care of it. So, self-monitoring is effective for anorexia? I don't think so. There's nothing wrong with them. So, false. And then you have to be aware of yourself and how you feel about your body and how you feel about your relationship with food. You're going to be seen as the enemy because you're trying to get these people to eat and eat correctly. So they're going to look at you and say, gosh, you're trying to sabotage me. You're trying to make my life awful. You're trying to make me fat. I hear, that is kind of a common theme. So just kind of realize it's kind of a tough road to hoe if you want to go into this kind of mental health nursing. And that is 20. Stop the share. Stop the share. Hi. Go back and close this and go back here and open 21. So we talked about this in class. Okay, 21. 21. And open 21. It's taking forever to open. Sorry. Somatoform. Okay. So we'll skinny that down and we'll come back to here and share the screen. 21. Okay, screen sharing, 21, good, good, good. Okay, and we're gonna run this slideshow from the beginning. Okay, somatoform. Somatoform in of itself is anxiety and stress manifested in a physical form. So stomach ache, headache, usually pain, chest pain is the big one you see with somatoform pain syndrome. Freud, he said usually that it's suppression of these emotions and it causes hysteria. And there's no basis of hysteria. It's all emotional. So, Freud came up with a lot of interesting ways to deal with hysteria. I don't know that necessarily I think that Freud was very beneficial. I think a lot of times that Hildegard Peplau, she didn't realize how impactful she was with this communication thing. If women can talk about something, they're more than likely to feel better. So that's cognitive behavioral therapy. That's Beck, Hildegard Peplau, love it. Freud, though, he's what your textbook goes back to. Three essential features. We have physical complaints without any organic cause. Psychological factors can initiate or begin, exacerbate, or maintain symptoms. So the more stress you have, the higher your pain would be. Uh, Likewise, the less stress you have, the less your pain would be. And usually it's not under conscious control of the person. So they cannot stop themselves from feeling these feelings. We have different types. We have somatic symptom disorder, which is usually headache, upset stomach kind of thing. Conversion disorder, which we talked about, is kind of cool. Well, cool to study, not to have. But this is where it attaches itself to your senses. So you have to take a test and suddenly you're blind. You have to play a piano recital and suddenly your hands don't work, that kind of thing. You can't feel or touch. Pain disorder, that's the chest pain, could be other pains. And illness, anxiety disorder is just another kind of way they describe somatic symptom disorder. They're pretty much the same thing. So um, onset symptoms experienced in adolescence, but we don't diagnose until older. You'll find that in the next chapter. Kids are not diagnosable because they're changing so easily. It can be chronic, it can be recurrent, and they do doctor shop because people don't believe them. They're experiencing these things because you can't find a reason for them. So clients usually are pretty pessimistic about getting any help. Says the following statement, true or false, when they have somatic symptom illness, are they able to voluntarily control the symptoms? And that is a big no. They can't control it, so it's false. Some related disorders, and these are underneath the control of one of the people involved. So malingering, these are the guys that come into the hospital and they stay and they have pain and they're with a doctor who gives them pain medication, so they stay. Or they come in and they know what they're doing. They claim and file insurance claims and then they catch them on camera and they're like lifting a car or whatever. So that's called malingering. Money is usually their motivator or something that they're getting that is physical to them. It's called malingering. So mal means bad. So hanging out and being bad. Factitious disorder is Munchausen's, and that's where people sabotage themselves to be admitted, to get attention. I always think back to, the one episode of House, this woman was deliberately injecting herself with heparin and then having nosebleeds and things like that. So that's Munchausen's. She was doing it to herself. And then Munchausen's by proxy is another factitious disorder, and that's where they do the deed to another person, usually a child. We talked about this in class, old Gypsy Rose and what she did and what she experienced. They can control what they're doing versus people with somatoform disorder have no control at all of what they're doing. Etiology of somatoform, again, it's this internalization, this suppression. And alexithymia is just another kind of manifestation of their stress and anxiety that they've suppressed in a physical form. Now, what they get from this is they get primary gains and secondary gains. Primary gains are direct benefits of being sick, which is relief of anxiety. Secondary gains are external, so attention. Kids are cleaning the house for you. Somebody comes to visit you in the hospital. It's a secondary gain. The primary gain is that they get the relief of the anxiety. People say it could be biological. There's differences in regulation and interpretation of stimuli. Some are more likely to overreact to stimuli, and other people are more likely to underreact to stimuli, and they suppress it, and that causes somatoform. So the big thing culturally, like I said, I know about falling out, but these others, I don't know what they are. They're in your book, they're across different cultures. I'm not going to ask you these questions. Just kind of be aware that culturally, somatoform does happen across the board. It's just called different things. Okay. Management. Well, we can give them antidepressants, SSRIs. We can send people to a pain clinic, even if it is psychosomatic, or even if it is somatoform disorder. It doesn't mean the pain's not real to them. It is. And pain clinic is trained on how to recognize those kinds of things, and they can help people with somatoform. So not just with pain medication, but other relaxation and other forms of treatment. So therapy groups are good, education is good, but they have to have insight and understand that they are suppressing these emotions. It's causing a physical reaction, and the physical reaction they're having is not really accurate. Okay. And if they get rid of their stress, they're going to be better. And that requires a lot of belief, a lot of willingness to accept something that may be unacceptable. So anyway, question number 2. A client with factitious disorder develops symptoms primarily for attention. Well, that is true. So that woman who was injecting herself with heparin, so that she would have nosebleeds and bleed out and whatever, she was looking for attention. Assessment, psychosomatic disorders, somatic symptoms. We want to rule out the physical first. It's very important, because if somebody comes in with chest pain, crushing chest pain, you're going to, like we talked about in class, you're going to do troponins, you're going to do chest x-rays, you're going to do the whole workup to make sure it's not something physical. If it's not something physical, then it's probably something mental, and we're just going to treat it that way. So, but you have to rule the physical out first. So medical history, you're going to look at the current status, someone who can't see, were they born blind? Did they have trauma? Did something happen to make them blind? People who just say, oh, whatever, it's all going to be fine. They're blind, and they just came on all of a sudden, but they just, whatever, they don't care about it. Labelle indifference is what that's called. And it's a kind of conversion disorder. It's another way of dealing with stress, I know you probably all see the memes with nurses saying, oh, it's fine, and there's a dumpster fire behind us. So that kind of is an example of labelle indifference. Then we want to look at their motor behavior, their general appearance. They're going to be very labile. Thought processes, they really don't focus on their emotion. That's the problem. They need to focus on what they're feeling. Not a lot of insight. Again, they don't recognize that anything's wrong. They focus on their physical problems. And that's irritating to family members, because their roles and relationships are going to be challenged. If my husband says, I understand that you have pain in your feet and you don't want to go out and go dancing. I understand that. Well, if there's nothing physically wrong with my feet and it's all in my head, that's going to strain our relationship. So a lot of teaching with the family members to just say, hey, we won't be out long. It's going to be quick. Let's just go do this. And, just make sure people are engaged. Outcomes, we want them to understand that their emotions are what's doing this to their body. And other than talk therapy, there's not a lot of ways to get them to understand that. So we want them to verbally express what they're feeling. So a lot of asking them, how does that make you feel? Using feeling words, helping them demonstrate coping mechanisms, identifying other ways they can cope to get rid of this anxiety and this stress so that you don't have these physical symptoms. And then just remember food, drink, normality is very important for them. Routine is very good. So teaching, expressing emotions, yeah, journaling is good. You can do that. That's a good one. I've not used that a lot, but sure. It's all about helping them identify what they're feeling and, admitting it aloud. Can make the referrals out to pain clinic. People in pain clinic know what a somatoform disorder looks like. They know how to treat it. Support groups, very helpful, but only if they're really insightful. And then try and keep them involved in things they enjoy. Which approach is problem focused? So we're looking at the problem, which is understanding their emotion. Okay. We can do all these things to help them relax, but it's not really solving the problem. Progressive relaxation, deep breathing, guided imagery. Those are all interventions we can do to help them relax, but not really help them solve the problem. So we want them to get out there and focus on this role-playing behavior, on how they would physically address specific anxiety-producing situations to help them solve their problem. And then talking with them about how did that make you feel when that bank teller yelled at you. Not that they would, but just as an example, how did it make you feel instead of stuffing it down and saying, oh gosh, or blowing up? They can say, well, they can be assertive. They can say, when that bank teller blew up at me, it made me feel very angry. Well, then what kind of plan can we have to deal with your anger? Because that's a feeling word that we can deal with. So and then mental health promotion, assisting them to deal with their emotional issues, gaining knowledge. And then you got to deal with your own, because nothing is more frustrating than someone who does not have a physical problem, but still is complaining of a physical problem. It's so hard to understand. Um, if you don't have, if you're not having a heart attack and you don't have intercostal chondritis and you don't have asthma, why are you complaining of chest tightness and pain? It's because you're stressed out. Get over it. I mean, some people may feel that way. So just be aware of how you feel about those situations and moving forward. Okay. All right. So stop share. One more chapter to go. Let me close this. Okay. I don't know why my computer is being weird. I'll do this. Modules. Children. We're going to talk about neurodevelopmental with children. I think that's chapter 22. I have it split. I used to talk about neurodevelopmental with children in chapter 23, which is behavior with children. So we're just kind of doing one and then the other because I want to separate them out a little bit better. Neurodevelopmentally are things kids are born with versus their behaviors, which are acquired or learned. So trying to separate it out for you a little bit. Okay. So let's go back to the Zoom. And we are going to share. And we're going to share chapter 22, neurodevelopmental disorders. So I'm screen sharing, so I hope I am. Slideshow from the beginning. Now, this is the one we did not get to talk about. So let's spend a little time talking about it. Neurodevelopmental, again, these are things that children are born with, not acquired or developed. That's next week, chapter 23. Okay, again, you cannot diagnose a child. Children are rapidly changing, growing, being altered. They don't have the cognitive abilities as adults. So usually mental illness and mental health, we don't look at in children, unless it's something really glaring. We don't look at in children as diagnosable. Neurodevelopmental, however, is something that, like I said, they're born with. We're going to see it happening. And it's pretty easy to say this child has autism, this child has ADHD, this is the criteria for it, and that's just what they have. So these are more considered physical ailments versus emotional or mental. Autism spectrum. Autism spectrum is a big bridge. It covers a lot of things underneath of it. So for autism, just remember it's pervasive, usually some severe impairment of reciprocal interaction, either communication or physicality. So no hugging, no eye contact kind of thing. Previously, pervasive developmental disorders were called that. Now it all falls under what's called autism. And it can be very mild to very severe. And I have grandchildren, and I have 4 grandchildren who have autism. And we have Tristan, who's actually 16 this year, and he is nonverbal, been nonverbal pretty much his entire life, all the way over to Novalee, who is, how old is she? She's 10? I think no, she's not that old. She's either 9 or 10. And you would never know there's anything wrong with her other than she doesn't hug and she doesn't make direct eye contact and things like that. So that spectrum is very, very real. Presents in early childhood, more prevalent in boys. Characteristically, they have little eye contact, very few facial expressions, limited gestures. They do have some stereotypical motor behaviors, however, like sometimes they flap, sometimes they, head bang, things like that. That's very stereotypical. Limited capacity to engage with peers or parents. They don't smile a lot or have spontaneous enjoyment. Their affect is usually pretty restricted or flat. They don't pretend. That's kind of unique to them, is that they really are in one sphere of existing. They used to think it was rare. They used to think that it was because of MMR. There isn't any research for that. They know there's a genetic link in there. It just kind of happens. If it's caught early enough, they can actually become quite interactive with the world. So we want to decrease behavioral symptoms and promote learning and development. So a lot of early language therapy, special ed, cognitive behavioral therapies, or you can do some medications. Related disorders, tic disorder. That's a related disorder. My son has that. It's pretty chronic, motor tic. Now, if it's motor tic and language tic, that's something that they call Tourette's. If it's not both, it can be each one singularly, but that is not Tourette's, okay? Learning disorders fall in there under autism spectrum, motor skill disorders, communication disorders, elimination disorders. All those fall underneath autism spectrum. Okay, I know they're not autism, I know, but for billing purposes, that's where they fall. Okay, they're each individual related disorders. Okay, tic disorder. Sudden, rapid, non-rhythmic, stereotyped movement or vocalizations. We can treat them with antipsychotics. We can treat them with Risperdal or Aripiprazole. For tic disorder, It really depends on comorbidities. If they have ADHD or something else on top of it, you don't want to give them something that's going to exacerbate tic disorder. So those Risperdal, which my son ran a little bit on Risperdal, really not beneficial for his tic disorder. In fact, I think it made it worse. But your book says we can treat him with that. We tried a little bit of Depakote, anticonvulsant. Sometimes you can treat them with that. Go to a specialist. That's the big thing. Take the child to a specialist. Neurological involvement is something they're born with, and you just need a specialist, not a general family physician. Learning disorders, usually their trouble is in written expression or writing. So, but they can have trouble in math below the level of other people, can interfere with everything from academics to social. So if they have learning disorders, that their perception of things are just different. So again, early intervention, making sure there's nothing comorbid with it, and usually IEPs and things like that will help them through high school, college even. Motor skill disorders, there's things called stereotypical movement disorder. This could be almost like Parkinson's with the pill rolling in the hands. Sometimes they will bang their head against the wall. My friend had a granddaughter who did that. So she had to wear the helmet. Those are self-inflicted injury, with pain not deterring you from doing it. And then developmental coordination disorders, these are just really clumsy kids. Asperger kids usually fall into this one when they have a coexisting communication disorder. So lots of sensory things, adaptive physical education to get them where they can move about safely. That's very helpful. Communication disorders, we have a lot of different kinds. It's a deficit in language, speech, communication severe enough to hinder development, including socialization. So language disorders, speech sound disorders, so stuttering. Social communication disorder, basically selective mutism. If they are in a large enough classroom with other kids, they don't talk, kind of thing. And then we have elimination disorders, encoparesis and enuresis. Encoparesis has to do with stool. And for kids, most of the time, if it's innate, involuntary, they're born with it, something is just not working for them. I often think of little guy I used to take care of. He was developmentally delayed. He was in bed most of the time, had to wear diapers because it was all involuntary. And then enuresis, same thing. Most of the time, if it's involuntary, that kind of situations. Now, more common in boys and girls, but can it be intentional? Can they go behind a plant and, take a poop, or can they go behind a plant and pee? Well, yeah. But that's more, again, if it's intentional, it's more behavioral. And that's next chapter. So I don't want to go too far in. ADHD. This is another psychoautism spectrum. This is another one of those neurodevelopmental. It can be inattention or overattention, but the big thing with ADHD is that impulsivity, marked impulsivity. Diagnosed usually when kids get into school, they're fidgety, babies, noisy, disruptive. Lots of times they don't do their homework because they forget about it. They can't finish things they start, and lots of times they don't have a lot of friends, which is unfortunate. They think it has something to do with maturational abnormalities of the brain, the cortical arousal information. Some people say it's prenatal. Older parents actually may increase the prevalence of ADHD, older maternal age, exposure to drugs and alcohol, decreased frontal lobes. It's just all theory. Treatment goal is to reduce the hyperactivity or the hyperfocus, because it can be hyperfocus too. But the big thing is keep them safe. That impulsivity is really dangerous. So medications and behavioral changes. And you're working with the schools, so some sort of interventional IEP kind of things with the schools, you can assist in changing behaviors. Medications or stimulants and non-stimulants. Ritalin is a stimulant, Adderall is a stimulant, you got Dexedrine, Cylert. Those are non-stimulant, or those are stimulants. Antidepressants are a second choice. There's also non-stimulant. Strattera is a non-stimulant. There is a blood pressure pill, Clonidine, that works for ADHD also. Plus, it helps with sleep. So rewards are good. Medication compliance is very good. Dramatic, there's play, all kids need when they're having therapy or theory, they need assistance in talking about things. It's good to have them play. So dramatic play, a creative play helps them express themselves better. So amoxicillin is a stimulant, yes or no? It is no, it is not a stimulant. It is a selective norepinephrine reuptake inhibitor. So for ADHD, they're real fussy as an infant. They won't be able to sit still, carry on a conversation, they'll jump from topic to topic. Lots of anxiety, lots of frustration because things aren't happening fast enough for them. Sensorium is impaired because they can't concentrate. Now they can hyperfocus, but they can't concentrate. They may get into a video game and they may spend an hour in that video game and not realize that supper was done and they needed to come eat. And nobody came up there to pick them up. Very poor insight, very impulsive, low self-esteem. Lots of problems socially. So again, out from the other kids. Sometimes they're overweight, sometimes they're very thin. It just depends. Lots of times they don't sleep well. If they're very thin and they're on a stimulant, you got to watch that because you're going to have to increase finger foods. You're going to have to increase what they're intaking, and a lot of times, like no pop, nothing with caffeine. And a lot of times what parents will do is if they're on a stimulant, they'll take a summer break. So when they're not in school, they don't take their ADHD medication. And that's considered okay because then they tend to gain their weight back. So safety, big thing, safety and completion of goals. So it's very important that we teach them to respect boundaries, age-appropriate social skills, completion of tasks, how to follow directions. It's very important too. Safety, safety, safety. That's the big thing. So which finding would the nurse most likely assess in a child with ADHD? I think I've said it 15 million times, but this impulsivity is very, very dangerous. Mental health promotion, again, you're going to be working with the schools, the school nurses. You could be working with school teachers. If you're the nurse with ADHD, there's other assessment tools that are out there to figure out if they have something that's neurological like ADHD or autism, or if it's more behavioral like opposition defiant conduct, or if they're depressed. So big thing is just follow the chain of activities. So if you are trying to get somebody diagnosed with ADHD, there's a form you have to fill out from your physician. There's a form the school has to fill out from the physician as far as assessment, and then it comes back to your practitioner or your general doctor. And he kind of says, yeah, probably ADHD. Let's go ahead and do this. So your role, like I said, with children, you're going to be dealing with all of these people. Just kind of keep that in mind. A treatment option for ADHD includes educational interventions. It's true. It's very true. You really have to work with the teachers in the schools as a nurse for people who have ADHD, children who have ADHD. Make sure they're compliant with their medications, check out what's going on in the home. And then you have to realize your own parenting beliefs, and how it may differ from others. Focus on the child's strengths, not just the problems, because that really, if you focus on the problems, it's going to cut that self-esteem down even further. Ask the parents how they're doing. Do they need respite? Do they need help? Because ADHD children, autism children can be very taxing and very exhausting. If you're always on, always being that parent, you never have time to just be yourself. So this I hope it made sense. Hope it makes sense to you. If you have any questions, just let me know in the next class. I'm gonna stop the share. And that is all the chapters for this week. 2 more chapters left in the book. Next week, I'll come in and we'll talk about uh, behavioral disorders in children and cognitive disorders in the elderly. And that'll be the whole book. And I hope our last class, we're going to be doing a case study over delirium, which is a cognitive disorder. And then we're going to have, I'm hoping to be able to put everything into one great big Kahoot that we'll be able to go and review the final exam information on the Kahoot for you. So I guess that's it for today. I'm going to go home and I hope you guys have a nice weekend. See you next week.